rotators, very similar to the hip, where it gets so confusing because you have to think about putting them into the opposite direction for the motion that you're doing. 90-ish degrees, if they're having impingement or issues, you can have them slightly below. Towel underneath the humerus because you want that shoulder in line with the body, so you don't want them into any kind of horizontal deduction, and you don't want them into any sort of extension. So just enough to make sure that humerus is in line with the body. And if I want to do concentric shoulder internal rotation, where am I going to start the arm? External rotation. Now, again, with how easy it is to have some like anterior or posterior subluxation or any shoulder problems, you don't want to have your patient at full end range and then try and do a quick stretch there. You're not trying to get a capsular end-feel or anything like that. But you want to make sure they can get to that motion. Any pain there? Can you show me if you can do that on your own? So she can go start in end range, get into internal rotation. So I'm going to bring her just slightly out. Sorry, I don't want to pull your hair. Stabilizing on the shoulder, and then again, distal force. So I'm going to have you pull your hand back down just like that and pull. Any pain? Breathe, exhale. All the way in, all the way in. So one thing she's doing, there's two compensations that she's already kind of doing that you want to watch for. What would one possibly be?
Elevation of the shoulder.
So if her shoulders, or excuse me, if her elbows flex to 90, she's starting to bring it out a little bit. She's starting to try and kick in some of those triceps. And then also she's trying to flex, or excuse me, adduct that shoulder down a little bit more, trying to kind of pull down with the shoulder. So those are the things you want to watch for, cue for. And then kind of going back to what Dr. Parker was saying, that might be part more of me applying, excuse me.
Bless you.
Worse. So much, sorry, too much force for what your patient's level of strength are. So we're gonna do that again, and pull, breathe, exhale, any pain, try and keep that elbow flex like this, we're gonna come straight down through your stomach, and pull, there you go. Any pain? Okay, so then if I wanna do eccentric, I'm gonna hold here. Exhale, good job. Any pain? And again, you don't wanna bring them back so they're getting any kind of anterior subluxation, so be careful of how far you're pulling them back. If you start noticing any kind of weaknesses, and checking with your patient always, any pain, discomfort, symptoms, etc., etc. So then concentric shoulder external rotation. How am I going to have my patient start? In internal rotation. Same thing, I'm going to show my patient, can you bring your arm back like this? Any pain? Can you do that on your own? So she has the available range of motion and strength. So quick stretch, push, all the way up, and exhale. Any pain there? And then I'm going to push you back, slow me down.
When you're with the patient, are you typically telling them, like, are they just pushing pretty much as hard as they can, or will you say, like,
Match
give
my
me
resistance.
20%? Or
It depends on the patient. We give that answer a lot, right? It depends on the patient. Usually I'll say just match my resistance, or sometimes you'll find patients prefer that kind of cueing. Give me 50% maximal effort. Give me 25% maximum effort, something like that. So again, it just depends. The one that I'll typically go to, or the cueing that I typically say, is just match my resistance.
And do you have you just have a resistance in mind for that person?
Depends on your patient.
Yeah.
If it's, you know, a pitcher who might be stronger athlete, I laugh at my CrossFitters because they're so strong, and then when you try and do internal or external rotators, I'm like using the pinky.
Right, right.
Anyways, what do you do?
Yeah, again, usually when I'm doing this, it's not for someone who's like very strong in the motion that I'm working on. So I usually just tell them light contraction. You know, we're not wrestling. Like we're trying to get muscle activation, and then I make sure they can do the motion without compensation, and then I'll add resistance as needed. But again, like a lot of impingement patients that there's some tendon issue with it, I'll do, you guys learned cross-section massage
Yeah.
So you do a lot of that, and then I just want light muscle activation. I might even be focusing on the eccentric component mostly. And again, I want light contractions to help it heal. If it's, like a CrossFitter or impingement and it's later on, they're feeling better, now we might add some resistance, but I might be using this as preparatory for doing something else. So we might do this light just to make sure it's feeling good, correct compensations. Now let's have you grab a band, or do some other more advanced exercise.
Elbow flexion extension. So patient setup is going to be the same for elbow flexion extension. I'm going to actually bring this down just a hair. I don't know if you guys can see that at all here. Just gentle stabilization at the shoulder. So relax. For flexion, it's going to be distal wrist and have you bring anything there. You can do that on your own. So I know she's at least the 3 out of 5. And then again, you're not going to have them in full extension before your quick stretch, just a slight bit of an elbow bend. And I'm going to have you pull against my resistance. Pull, breathe, exhale, any pain. So that's concentric. I'm going to stay there. I'm going to pull you straight, slow me down. A little less resistance. There you go, just match me. Exhale, any pain. So then triceps, I'm going to have her start in flexion and push. Good, exhale, any pain. Good. I'm going to bend your elbow, slow me down. Good. Any pain?
And then I would just maybe not have her completely on the opposite side of the table.
Well, that was more on her arms up here. Sorry.
And that'll help your line of force at the end of range extension, not having to move around the table as much. And she kind of moved out of the way for the video, so at the bottom of the range, her elbow was off to the side a little bit more, but as she was coming up, it was getting more directly in line with how she's going. So when you guys are doing it, not worrying about a camera in the way. Yeah, so it's hard to get your elbow completely down right there, so if you're off a little bit to the side to start, but as you're coming up, get your elbow directly in line.
And then one thing on my favorite, we're hearing assessing if this is hurting when they're doing this, you can bring down a smidgen. Any questions about IR, ER, elbow flexion extension?
Where was your line of force for the internal?
For internal rotation, so here, and then she's just coming down. It's hard, you can try and be here, as long, I was trying not to block the camera, as long as you're keeping your body out of the way. But I was also, depending on the size of your patient, my arm's still in the line of force and having her pull down.
If you're able to do it directly at 90, then their forearm should stay off the table. If she's angled down a little bit, then her forearm's coming onto the table, so that really throws off the line of force there.
Where she's coming here. You want it to 90. I was just saying if your patient has some impingement and it's hurting them to be there, you just want to bring them down a smidgen.
So part of your intervention might be a lot of soft tissue joint mobilizations to make this position more comfortable. Now we want to activate here, and you might need to stay within a small range first. So again, lots and lots of clinical variables. We just want to make sure you guys can do it in a basic position and apply your lines of force at this juncture. Should we just do wrist flexion and extension now? And okay.